Ether. Before 1846, surgery was a death sentence of a different kind, not just from the procedure itself, but from the pain. Patients were held down by 4 or 5 men. Surgeons were judged on speed, not precision. The fastest ones could amputate a limb in under 90 seconds. Not because they were skilled, because every extra second was another second the patient was conscious. Then a Boston dentist named William Morton walked into Massachusetts General Hospital on October 16, 1846, and changed everything. His patient was a young man with a tumor on his jaw. Morton soaked a cloth in sulfuric ether, a compound chemists had been experimenting with recreationally for years, at ether frolics, where partygoers inhaled it for laughs, and held it over the patient's face. Within minutes, the man was unconscious. The surgeon operated. The patient woke up, looked around, and said he felt nothing. The room was silent, then it erupted. Ether works by flooding the central nervous system with a depressant that disrupts the normal electrical signaling between neurons. It doesn't target one specific receptor. It interferes broadly, suppressing consciousness, sensation, and muscle control simultaneously. The effect is total. The body doesn't just stop feeling pain. It stops registering that anything is happening at all. But ether had problems that became impossible to ignore. It was violently flammable. Surgeries occasionally ended in fire when it came near a gas lamp. It caused prolonged nausea and vomiting during recovery, sometimes for days. The induction period was slow and often terrifying, with patients passing through a stage of wild agitation and hallucination before going under. And the margin between an effective dose and a fatal one was uncomfortably narrow. Medicine needed something better. It found something worse first. Chloroform, the beautiful killer. Chloroform arrived on the scene just 1 year after ether, in 1847, introduced by Scottish obstetrician James Young Simpson. It was everything ether wasn't: fast-acting, non-flammable, and pleasant-smelling. Patients drifted under in seconds, rather than minutes. Surgeons loved it. The public embraced it. Queen Victoria herself used chloroform during the birth of her 8th child in 1853, which effectively ended the moral debate about anesthesia in Britain overnight. For roughly 50 years, chloroform dominated operating rooms worldwide. Then the deaths started becoming impossible to explain away. Chloroform works on the same principle as ether, broad central nervous system depression, but it is dramatically more potent and has a therapeutic window so narrow it borders on non-existent. The difference between a dose that keeps someone comfortably unconscious and a dose that stops their heart is almost invisible. Chloroform sensitizes the myocardium, the heart muscle, to adrenaline, meaning any spike of stress during surgery could trigger sudden cardiac arrest without warning. Patients who seem perfectly stable would simply stop. By the early 1900s, statistical analysis of surgical deaths revealed that chloroform was killing patients at a rate several times higher than ether. But the drug had one more disturbing legacy before it left medicine. Its ease of use and pleasant smell made it the weapon of choice for a different kind of predator. True crime cases throughout the late 19th and early 20th century repeatedly featured chloroform-soaked rags as tools of kidnapping, assault, and murder, a reputation the compound has never fully shed, despite the fact that Hollywood dramatically overstates how quickly it renders someone unconscious. The real timeline is 2 to 5 minutes of sustained inhalation, not the 3 seconds you see on screen. Nitrous oxide, the one that almost got there first. Nitrous oxide was discovered before ether, before chloroform, before any of them. Joseph Priestley synthesized it in 1772. Humphrey Davy, and one of the most celebrated chemists of his era, inhaled it in 1799 and wrote that it might be useful for surgical procedures where pain relief was needed. He had the answer in his hands 20 years before Morton's famous demonstration. He never followed through on it. Instead, nitrous oxide became entertainment. Laughing gas parties swept through Britain and America in the early 1800s. Aristocrats inhaled it at parlor gatherings for the euphoria and uncontrollable laughter it produced. It was a spectacle, not a medicine, and that reputation kept it out of operating rooms for decades, while patients continued suffering through conscious surgeries. Nitrous oxide works by activating opioid receptors and inhibiting NMDA receptors simultaneously, a dual mechanism that produces pain relief, mild sedation, and a floating sense of dissociation. But it cannot produce deep unconsciousness on its own. At any concentration safe to breathe, patients remain aware, responsive, and able to protect their airway. That ceiling on its power is exactly why surgery moved past it to ether and chloroform. What nitrous oxide became permanently is the foundation of dental anesthesia. Mild, fast, reversible. In dentistry's hands, it was perfectly suited. Today, it's also used as an adjunct in surgical anesthesia, layered underneath more powerful agents to reduce how much of them is needed. And in the outside world, it never stopped being a recreational substance. The small silver cartridges used to charge whipped cream dispensers have become one of the most widely misused inhalants in the world, with the UK recording hundreds of thousands of users annually before banning recreational sale in 2023. The drug that could have gotten there first is still everywhere, just rarely where it was supposed to be. The gap. What came between? The early 20th century brought a wave of refinements rather than revolutions. Barbiturates entered the picture in the 1930s. Sodium pentothal, thiopental, could be injected directly into the bloodstream and produce unconsciousness in under 30 seconds. No mask, no inhaled vapor, just a needle, and then nothing. It became the standard induction agent for decades and earned an undeserved reputation as a truth serum when military interrogators discovered that patients in a barbiturate haze were less guarded, not actually compelled to tell the truth, just too sedated to maintain their usual filters. Each of these compounds moved medicine forward, but none of them solved the fundamental problem. Anesthesia was still an imprecise art. Keeping someone at exactly the right depth, for exactly the right duration, without tipping into cardiac arrest or respiratory failure, required constant vigilance and significant luck. That changed with 3 drugs that redefined what anesthesia could be. Ketamine, the dissociative that wouldn't stay in its lane. Ketamine was synthesized in 1962 by Calvin Stevens, a chemist working for Park Davis Pharmaceuticals. It was developed as a safer alternative to phencyclidine, PCP, which had shown promise as an anesthetic but produced psychotic episodes so severe it was eventually abandoned for human use entirely. Ketamine was the compromise. Similar enough to PCP to work, different enough to be manageable. Patients under ketamine didn't look unconscious. They looked awake, eyes sometimes open, muscle tone maintained, breathing entirely independent, but they felt absolutely nothing, remembered nothing, and described the experience afterward as a profound sense of detachment from their own bodies. Researchers coined a term for it, dissociative anesthesia. The body was present. The mind had left the building entirely. Ketamine works by blocking NMDA receptors, glutamate receptors responsible for relaying pain signals and maintaining conscious awareness. Unlike ether and chloroform, it doesn't broadly suppress the nervous system. It surgically interrupts specific communication pathways, which is why breathing remains intact. That single property made it invaluable in situations where intubation wasn't possible. Battlefields, remote field hospitals, pediatric emergencies. It was deployed extensively during the Vietnam War. But ketamine refused to stay neatly inside the boundaries of surgical anesthesia. At sub-anesthetic doses, it produced vivid hallucinations, euphoria, and dreamlike states. By the 1980s, it was a club drug. By the 1990s, it was a Schedule III controlled substance. And then, in the 2010s, researchers discovered that patients with severe treatment-resistant depression experienced dramatic mood improvements after low-dose ketamine infusions. Not over weeks, like traditional antidepressants, within hours. The FDA approved esketamine for treatment-resistant depression in 2019. Ketamine never stayed in its lane, and medicine is better for it. Midazolam, the forgetting drug. Midazolam doesn't put you fully to sleep. It does something in some ways more unsettling. It makes you forget you were ever awake. Introduced in the late 1970s and belonging to the benzodiazepine class of drugs, the same family as Valium and Xanax, midazolam became one of the most indispensable tools in procedural medicine, not because of what it suppresses, but because of what it erases. It produces anterograde amnesia, the complete inability to form new memories during the period it's active. Patients given midazolam before a procedure can be fully conscious, responsive, even conversational, and remember absolutely nothing afterward. It works by binding to GABA receptors and dramatically amplifying their inhibitory effect, selectively disrupting the hippocampus, the brain region responsible for encoding new memories into long-term storage. The sensory experience happens. The emotional experience happens. The brain simply never files it away. This property made midazolam the standard pre-medication for surgical procedures, endoscopies, and ICU sedation. A patient terrified of their upcoming colonoscopy is given midazolam beforehand. They remain calm, they cooperate, they go home with no memory of the procedure at all. For the medical system, it's efficient. For the patient, it raises a question medicine rarely stops to ask. If you experience something painful but remember nothing, did the suffering count? Midazolam also carries a darker footnote, and it became one of the 3 drugs used in lethal injection protocols across the United States, intended to sedate the condemned before the paralytic and cardiac agents were administered. Its use in executions has been repeatedly challenged in court after documented cases where the sedation appeared insufficient, raising the possibility that inmates were conscious but unable to move or signal distress. A drug designed to make patients forget their fear became a subject of constitutional debate. About cruel and unusual punishment, propofol, the white milk of amnesia. Propofol looks like skim milk, It's a thick, white emulsion delivered through an IV, and it works faster than almost anything else in the anesthesiologist's toolkit. Within 40 seconds of injection, a patient is completely unconscious. The induction is so smooth, no agitation, no hallucination, no transition, that patients often describe it as simply blinking out of existence. It was developed in the 1970s and approved for clinical use in the late 1980s. Within a decade, it had become the most widely used induction agent in the world. Propofol works primarily by enhancing GABA, the brain's main inhibitory neurotransmitter, effectively turning down the volume on neurological activity across the board. But unlike barbiturates, which linger in the system for hours, propofol is metabolized and cleared with extraordinary speed. Recovery is clean and fast. Patients wake up without the heavy grogginess and nausea that plagued earlier anesthetics. It transformed same-day surgery from a logistical challenge into routine reality. But propofol has a shadow. Its fast action and smooth sedation made it desirable outside the operating room. Michael Jackson died in June 2009 with propofol in his system, administered by his personal physician in a Beverly Hills bedroom to treat chronic insomnia. The drug was never designed to be used without continuous monitoring, without resuscitation equipment, without an anesthesiologist watching every breath. Used that way, the same property that made it revolutionary, the speed at which it suppresses consciousness, becomes the speed at which it can stop breathing entirely. Jackson's death put propofol on the front page of every newspaper in the world and forced a conversation about access, misuse, and the gap between what a drug does in controlled hands versus uncontrolled ones. Every anesthetic on this list began as a solution to the same problem. How do you cut into a human body without destroying the person inside? Ether answered that question for the first time. Chloroform refined it and nearly killed it. Nitrous oxide proved that timing and context determine whether a discovery becomes medicine or entertainment. Ketamine expanded what the answer could even mean. Midazolam raised questions about consciousness, memory, and what we even mean by suffering. Propofol perfected the mechanics. But the story underneath all of it is the same story as every other drug on every other list. The line between medicine and poison is not drawn by the compound. It's drawn by the hands holding it, and whether those hands know exactly what they're doing.